Hey everybody, you are listening to The Poison Lab, a show about poisoning for people who manage poisoning. I'm your host, clinical toxicologist and emergency medicine pharmacist Ryan, and this is another high-yield highlight episode looking at some of the amazing research that is presented at the North American Congress of Clinical Toxicology each year. We did an episode like this last year where we brought on a panel to review the 10 to 15 most interesting abstracts that we thought from the year's research. And we're going to do it again this year with another amazing expert panel. You will be hearing from people who you've heard on this show in the past, Dr. Emily Kiernan, Dr. Joshua Trebach, Dr. Frank Paloucek, and Dr. Grant Comstock, who are all coming on to share what they believe were some of their favorite abstracts, their notable limitations, and their implications for the future. We did also just release another NACCT abstract review focusing just on acetaminophen research. This is going to be a little bit different in that we're not interviewing the authors. We are actually doing a panel discussion. Now, be sure to check the show notes for a link to the published 2023 North American Congress of Clinical Toxicology abstracts. We will read out which number we're talking about in the title of each abstract, and you can find it in that PDF document if you want to read more or read it before we start talking about it. I will also put in the show notes the timestamp of where we start talking about each abstract. So if there's one you want to skip to hear more about, feel free. As for the actual abstracts that we discuss on the show, we kick it off with number 225, Methotrexate Toxicity in the Setting of Therapeutic Error, a multicenter retrospective review, and have a great discussion about the serious problem of accidentally taking your weekly methotrexate daily, as well as how we triage it and the limitations in our understanding of who develops toxicity. Then we jump to abstract number 251, Oleander seeds and candlenut weight loss products strike again, and have a discussion of how poison centers and public health can work together to prevent these toxic products from reaching people. We then jump to a riveting discussion of abstract number 2, Efficacy of sodium tetrathionate when administered intramuscularly for the treatment of acute oral cyanide toxicity in a swine model, and get into a discussion of the limitations of our current antidotes for mass cyanide poisoning and the future of what cyanide antidotes might look like. We then jump to abstract number 10, Is Hour Enough After Out-of-Hospital Naloxone for Opioid Overdose? Prospective preliminary data from real-world implementation of the modified St. Paul's early discharge rule. This is a great discussion about when patients are actually okay to leave the emergency department after an opioid overdose if they've received naloxone, and we'll hear tons about the limitations of all of the current decision rules that exist. After a brief intermission, we discuss some very punny topics related to NACCT titles and have a bit of a rambling discussion about the use of rivastigmine for anticholinergic delirium and jump right back into abstracts. We then move into abstract number 5, which is randomized human trial of ANEB001, a CB1 receptor antagonist, in 3 doses of cannabis, and talk about the implications of what having a reversal agent for THC intoxication would be on many of these pediatric THC ingestions. We then move on to talk about abstract number 216, successful use of expired physostigmine to treat anticholinergic delirium in a pediatric patient, and have a discussion on the many factors that go into using expired medications and what the real risks are if there's benefit for patients. We follow this up with abstract number 202, Enough Negativity, clinically significant salicylism with first detectable concentration 12 hours post-ingestion, and have a sobering discussion about how difficult it is to truly rule out salicylate toxicity when there's a strong history of ingestion. Finally, we end our discussion with abstract 267, high sensitivity troponin is frequently elevated after carbon monoxide exposure, and discuss the problems that arise with this troponemia that develops in response to carbon monoxide toxicity and what to do with it. We have some fantastic discussion. We weren't able to credit all the authors who created this amazing research for us to discuss, so I encourage you to check out these abstracts and see who's doing this work that's going to help us change the way we care for patients. I took away so much from the discussions with these really bright minds in toxicology. So whether you work in tox or you're not even in healthcare and you just want to hear about what some of the cutting edge research is in poisoning and drug overdose, get ready as we review what we believe to be some of the most interesting research out of the 363 total abstracts that were published at NACCT this year. Okay, let's dive in. Hey everybody, you are listening to The Poison Lab, a show about poisoning for people who manage poisoning. And oh boy, do we have a lot of people who manage poisoning today. This is a very special episode, one I am really excited to share with you all. We have some brilliant toxicology minds who are going to be dissecting some of the top abstracts from the North American Congress of Clinical Toxicology that was held in Montreal, Canada in 2023. You just heard an episode where we covered all of the acetaminophen abstracts. And no, none of those are going to be on this episode. We are going to be diving into some other abstracts that are interesting to talk. So I have an all-star panel with me today. Each and every one of the people you're about to hear from has been on the show in the past. We have Dr. Emily Kiernan, Dr. Frank Paloucek, Dr. Josh Trebach, and Dr. Grant Comstock. So if you all wouldn't mind, if maybe a listener hasn't heard you on one of the episodes in the past, would you mind introducing yourself, who you are, where you work, anything else you'd like to share?
I'm Emily Kiernan. I'm an emergency medicine physician and medical toxicologist at Emory and the Georgia Poison Center in Atlanta, Georgia. And my favorite podcast is this one.
Did I make it to your Spotify Wrapped this year?
I don't have Spotify.
Oh, all right. Perfect. Thank you for joining today.
I'm Frank Paloucek. I'm currently retired, although they call me fake retired because I'm at work too much for no reason anyone understands. I was at the University of Illinois for all of my professional career. I was an emergency medicine pharmacist, one of the earliest ones there, and one of the earliest in the first 35 people that ever got ABAT certified. I ran an EM residency program in pharmacy. I'm probably most well known because of X, formerly known as Twitter, where I'm known as It's All Tox, and I usually say things that offend people.
In a usually well-meaning manner, but though I can't say for all of it.
I can trust that you'll edit my malaprops and offensive language.
I'm going to do my best, but if you'd like to cognitively pre-edit, I will also. Another thing that Frank has honed over many years is, I think, really an expert level of curmudgeon regarding literature. So I think you're going to be a perfect person to have on the panel today. So thank you for joining. Dr. Trebach, would you mind going next?
Oh, I would love to. Thanks for having me here. I'm Josh Trebach. I'm one of the medical toxicologists and emergency docs over in Iowa. I'm happy to be back on the show. I apologize in advance if my cats jump up to the mic and give a friendly meow. Their meows do not endorse or say anything particular about any of the articles we're going to discuss. Just want to get that out there in advance. I've already reviewed all the articles with them. They have their own thoughts, but they're not joining us today.
No cat favoritism. I appreciate it.
Yeah, are we going to see a hairball is my question. But yeah.
From me or the cats?
Cats.
Oh, yeah.
We have, last but not least, a good friend and colleague from right here in Wisconsin, Dr. Grant Comstock. Would you mind introducing yourself?
Sure. Thanks, Ryan. My name's Grant. I'm an EM doc and medical toxicologist at Medical College of Wisconsin, the Wisconsin Poison Center. It's a pleasure to be back. I just let Ryan know that I'm here in Door County right now at a very charming bed and breakfast on my baby moon. And I love that I'm spending it with you four. So
I think you were out of town last time we did this too. You were like in a
I
closet
was.
at your...
That's correct. Yeah, that's correct.
Well, I owe your wife, I guess, a mocktail.
Yeah. I know everyone but Frank, so it's a pleasure to meet you, Frank.
Can we revisit that at the end and then we
Sure. We'll table it for now.
So for the listeners, we're going to run through hopefully up to 10 North American Congress of Clinical Toxicology abstracts. There's about 360 published this year. So this is going to be the top roughly 5%. I was trying to think of what to call these. This is like, it's like sort of an award, but there was no objective assessment of the methodology or anything like that. So it's sort of like things that we found valuable. What would we call them, like the toxos or something like that, or the toxies?
I would call them the yuckies.
I like the yuckies.
Are you gonna make a little trophy to hand out next year? Like if we've picked your abstract, you get a toxie.
Oh yeah, we'd have to do this beforehand, or we could just do this live at NACCT next year. Maybe that would be.
I think that's a great idea.
the better. Yeah. So a small trophy, the Toxie Award for the group voted best abstract. So we're going to jump right in. I think I will go ahead and kick us off. And I kind of chose two. I chose one that I think is going to impact practice in the future, and one that is going to impact practice and already has kind of impacted my practice right now. And the first abstract that I wanted to talk about is, pause for dramatic effect and for me to find it.
Abstract number 225. Methotrexate toxicity in the setting of therapeutic error, a multicenter retrospective review.
Actually, before we jump in, I want to mention that we were going to have another guest on today. He was not able to make it, Dr. Dan McCabe. He made it last year. And this was the study I know that he wanted to talk about as well. And I really wanted to talk about it. So we are bummed that Dr. McCabe was not able to join us. But this is my shout out to Dan and appreciating his mind for both of us wanted to talk about this exact abstract. But
I feel like I have to ask, did you harm Dr. McCabe in order to take over this abstract?
I mean, I wouldn't check his methotrexate bottles. I'm not sure if there's a lot in there, but no, unfortunately, the timing just didn't work out. But this is one that I chose because we get called all the time about, oh, I accidentally took 2 of my amlodipine, or, oh, I accidentally took 5 omeprazole. I don't know how that happened. And a lot of times, it's not that big of a deal. When it comes to seeing serious problems from overdose, I get way more worried about intentional overdoses, suicidality, that kind of a thing. There's only a handful of drugs where therapeutic errors am I really concerned about, very serious effects, even death. And methotrexate is one of those. And methotrexate is kind of prone to therapeutic errors because it's one of the few drugs that many people prescribed once a week. So they'll say, take 20 milligrams once a week, and then suddenly somebody takes it 20 milligrams daily. And there are cases of people dying from taking that 20 milligrams daily for just a couple of days. So if somebody calls me and said, oh, I took my methotrexate dose every day, now I have a reason to be concerned. And then there's another problem. Let's say I get a call from somebody who double dosed on their, dofetilide, and I'm like, I'm nervous. I'm going to send you into the hospital. And then we can do some labs and evaluations there and know whether or not you're going to get sick. The toxicity of that drug occurs pretty much right away or within a few hours. For methotrexate, because of its mechanism, which interferes kind of with cellular replication, it can take days to develop symptoms. So even if you call me and say, oh, I took my methotrexate every day for a few days, even if I send you in, I don't know that I'm going to be seeing the symptoms that would occur at that exact moment. They might develop later. So it becomes an absolute conundrum for triage. So we were trying to solve this problem at our poison center. And I did a data pull looking back at other cases that we've had that had follow-up information so we could identify if these patients develop symptoms later. And I only had 10 patients. And I even pooled it with fatality reports to help increase my population to make some conclusions from. And we found some pretty crazy things. I mean, in the fatality reports, as little as 35 milligrams led to death, somebody taking 2.5 milligrams for 14 days. And then looking at our own internal data, we were seeing people develop toxicity on as little as 5 milligrams a day for 5 days, or in patients with some renal problems, 8 milligrams daily for 3 days. That's not very much. And there was other people who didn't get toxicity with those doses. And then when we looked at when they developed toxicity, we were seeing, end organ damage and neutropenia develop 8 to 10 days out. So am I supposed to send everybody who potentially took any therapeutic error into the hospital to be monitored for 10 days for the development of life-threatening toxicity? You can see why this is a problem. So we really need to develop some level of triaging into who gets sick, or at least how can we follow people who might get sick. That's why this study is so incredibly important. So this was a multi-poison center retrospective cohort study. And essentially, they looked at anyone who had multiple doses of methotrexate taken as a therapeutic error. So this actually excluded patients who had like a single acute overdose. So if you like took a whole bottle of methotrexate, you're out. That's kind of a different type of overdose, and we managed those differently. They ended up including 72 cases of methotrexate therapeutic error. These were older people, about 61 years old. In 68 of these cases, methotrexate was prescribed weekly. 86% of those cases, of those 68, took methotrexate daily instead of weekly. So let's look at what happened. End organ dysfunction was observed in about 43% of cases, so 31 of the 68. The mean duration and dose of methotrexate being taken daily was 6 days and a total of 73 milligrams. But this was the main takeaway. There was 2 deaths out of this from somebody taking their therapeutic drug incorrectly for just a few days. And what I really found important was that no patient developed organ system dysfunction if methotrexate was taken for less than 3 days or a total dose of less than 32.5 milligrams. So taking methotrexate daily when prescribed weekly can result in toxicity and death, but for the first time, we are trying to pool all of our data to create more of a triage decision rule and identify if there are any exposure scenarios that are lower risk, which in this data set was less than 3 days of continuous dose and less than 32.5 milligrams. So what do you guys think?
I was actually really excited to see that you had chose this one as well, because this is always such a challenge for exact reasons you said. These patients show up and they might have no symptoms or very little symptoms. And then the question is, well, this is such a dangerous medication in overdose or in toxicity. How do we manage this? And so to my knowledge, I don't think we have a lot of other good triage tools for PO methotrexates after a few days.
I think the abstract is an interesting first step. And it makes me interested to see what the actual paper looks like. Because I look at those cutoffs and I say, well, all right, am I, as working for a poison center or on call with a poison center, am I going to keep home the 70-year-old with maybe, grade 2 CKD with, who took 30 for 2 days, but didn't hit that 3-day and didn't hit that 30 milligram mark? I'm probably going to still send them in for charcoal for labs in a week or whatever. I'm still going to do some things. And so if it's one patient who, met that threshold of less than 3 days and less than 32.5 milligrams, well, then I'm not very compelled. But if there's a whole ton of patients who are under that threshold and still didn't get sick, well, then maybe that's a little more compelling. And maybe when we know a little bit more about the demographics of that cohort of patients, maybe then we can start to figure out the granularity of who actually you can keep at home. But as it sits in the format, they're in that jumble of abstracts there for the NACCT readout. I don't look at that and say, yep, I know where I'm going to go. It certainly maybe tells you there's a dose response threshold, but I think we probably all could intuit that to some degree. I don't know that those numbers mean a ton to me yet, but I'm certainly interested to see some more and to see this replicated elsewhere.
You bring up such a good point here on, just being careful in the interpretation, right? This is the largest study that we have, which is fantastic, but it's not all inclusive. There are data points that are not here. When I was trying to solve this problem for our center, a few years ago, I found a data point that would sort of be in contrast to this, where there was a patient that had 8 milligrams every day for 3 days, and they ended up developing organ toxicity. So as the population grows, as your sample population grows, you can be more confident in your conclusions and your sensitivity analysis of how likely your conclusion is to be correct. But obviously, there probably are going to be outliers here, especially we definitely see more toxicity in patients who have renal insufficiency. And I don't know how many of those were included in this study. And that is a huge impactor, in my opinion, one of the pieces that's a big decision maker in how likely someone is to develop toxicity. There are case reports of people who are on hemodialysis taking therapeutic methotrexate, like taking it as prescribed, and just dying because there's all sorts of issues with its clearance, and it can just build up. So there's a particular vulnerability to impaired renal function with those who are on methotrexate, even therapeutically, to the point where you can just end up, showing up with pancytopenia and all sorts of, severe toxicity and die regardless of the supportive cares that we can administer. So obviously, yeah, it's a starting point. It's kind of like narrowing in an area for us to start drawing a line, but I agree, there's going to be other variables that'll make that impact.
I wanna jump in here. I'm going to keep feeding off this thread, and I'm going to warn everybody. I should have before. I overthink everything. The renal function is important, as would be the concept of drug interactions that impact the tubular secretion. And why aren't we looking at that? The methotrexate, trimethoprim sulfa. Those are the two methotrexate deaths that I have witnessed in my career. Was dialysis patients taking once weekly as prescribed who got UTI doses of Bactrim or of a trimethoprim sulfa product and ended up having pancytopenia and death. That bothers me. 62 of the 72 cases here they took it every day. And then there were 10 cases they don't talk about much. So was that they took more than one daily dose on a day or a couple of doses a day, BID, 4 times a day because Q, all of that is questions I would have asked when I did walk by this poster because I really wanted to talk to the people about this poster. And there was nobody there, unfortunately, so I couldn't get answers.
But I agree. We should probably dive more into the granularity. More to be figured out in terms of when do symptoms develop? How should they be followed up? Who should be sitting in a hospital to watch for those things? But this was a good start, I think. And I appreciate that people are looking at this. So anyone wants to figure out the rest of those problems for us, that'd be wonderful. Okay.
Can I just ask the crowd, how many of you would give a patient like this activated charcoal? Because I'm afraid to say this out loud while it's being recorded. I probably wouldn't.
Right, because they've already taken most of it.
Yeah.
If you're polling the crowd, I would do the same. It's if you just took a big slug of it, then sure, let's give you some charcoal. But in this population, no, I'm with you.
Yeah. And what's interesting is it's got saturable absorption. So actually large ingestions, you don't even absorb that much. I get less worried about large ingestions than I do about a chronic, I take 10 a day for 10 days.
Well, let's just make sure they have intact GI mucosa then.
Does anyone want to make the argument that methotrexate has some gentle enterohepatic circulation? You could be a benefit.
No, I don't. I hate that term. I like the concept. Josh, forgive me, but I think we have grotesquely narrowed our focus here to enterohepatic when we should be talking about entero. I mean, there are things that have greater recirculation because of biliary secretion, but all drugs can go back and forth across that membrane. Drugs that have no biliary secretion at all. I think there were studies with multiple doses of activated charcoal done with pig intestines and in human beings that have shown that theophylline, which has nothing, I'm sorry, I'm an old man and I say theophylline that has no biliary secretion is well removed by multiple doses. And I think that is a not one-way semi-permeable membrane. It's a two-way. And as long as you can create enough of a concentration sink somehow, I think that your point's well taken. I'm not going to argue.
Yeah, no, I mean, I think I love activated charcoal, and I don't want to get too much on a sidebar here, but I really do. I think even amongst the residents and the fellows that I teach, they know that they're like, I ask them, what do you want to do next? And they're like, charcoal? I'm like, are you just saying that because I'm here? So I don't know. I'm a huge fan. I agree with you. I think that was that Berlinger paper where these patients got IV aminophylline, got activated charcoal, and it pulls from the plasma. It was so cool. So I think obviously we can't, this is really hard to study, right? The utility of activated charcoal in all these patients because the IRB, for some strange reason, won't ever approve me taking 100 healthy tox fellows and poisoning them. And for people who are listening, this is with heavy sarcasm. I don't believe in poisoning people intentionally.
I had identical twins, and I'm more than willing to still offer them up for scientific research at the age of 29. But I might start to like you. You said theophylline and charcoal in the same sentence.
All right. I'm going to rein us in here. I don't know if we had a pool going for like time to Frank bringing up theophylline, but if you had under 30 minutes, you did take the money. I went a little over on this one, but who would like to jump in next?
Abstract number 251, Oleander seeds in candlenut weight loss product strike again.
The reason I chose this one is because I have this, I think we all do in toxicology, have this love-hate relationship with the internet where we can do things like we're doing right now, and there's pictures of cats, and there's memes, and there's funny stuff. It's good dissemination of information. But on the other hand, people can buy these unregulated supplements and products and get into all sorts of things that we in the tox and the poisons world aren't a huge super duper fan of. And so this case sort of dives into an example of that. So this abstract's entitled Oleander Seeds and Candlenut Weight Loss Products Strike Again. Looks like it's coming from our colleagues over at the Maryland Poison Center and Maryland Department of Health. It describes this 55-year-old who took this weight loss product that they obtained off the internet. It's called, quote, Indian Nuts for Weight Loss. And it is supposed to contain a product called candlenuts, which are, I guess, typically sold as a weight loss agent due to their some of the effects that they can cause. I personally have not taken candlenuts, and so I cannot comment on their efficacy, taste, or other factors associated with candlenuts. But it sounds like this patient took these candlenuts and ended up coming to the ED about 12 hours later. They had some GI symptoms, nausea, vomiting, diarrhea, and unfortunately were noted to be hyperkalemic. So the potassium was 5.9 and they were bradycardic down to the 40s. And for all of us who are in the tox world, that immediately sets off the bells, whistles, red flags for, cardiac steroid poisoning, essentially. So it seems like that's what was triggered in the brains of the individuals taking care of this patient as well, because patient ended up getting a digoxin concentration checked, and it was above the upper limit of quantification, which is greater than 5 nanograms per ml. So the patient got all the digoxin immune fragments that the hospital had available, and heart rate improved to 60, yada, yada, yada. Patient ended up being discharged and was following up and was doing fine. But it was really cool, as opposed to, sometimes we stop studies there and we're like, hey, this is what happened. What do you think it was? But they took it to the next step, and actually utilizing the Department of Health Services, were able to analyze samples of these candlenuts, and we're basically able to find that this product contained yellow oleander, which is not ideal. That's probably one of the things that if someone said, hey, Josh, do you want to take this mystery product or this yellow oleander? I'll probably choose the mystery product like 99% of the time, unless the mystery product is also yellow oleander. So yeah, yellow oleander is super duper scary. It's a cardiac steroid, very very similar to sort of like digoxin, for example. And so the fact that this was in a product that someone could buy off the internet, the question is, who's taking this product that isn't coming to the hospital? Who is this person just found at home and they're not alive anymore, and no one bothers to sort of dive into this? And so it's pretty concerning. I think this isn't super duper surprising that this happened to those of us who are in the know about supplements and things in the internet and quality control for products like this. But I'm sure everyone on the line right now had a case of someone who took something that was from the internet that turned out to be a surprise product inside.
What?
In a good way.
No. The internet is always 100% reliable.
Yeah, really. So I really like to see that these authors did this. It was really cool. Thoughts?
Deeply envious of their public health department being that helpful.
We have gotten to work a lot with our health department, and they can do some really interesting testing. We've had them test products that we've seen create some pretty nasty effects in patients. And if we thought it was going to be a public health concern, they would do some product testing for us. We also collaborate with them. We work to help track cases of EVOLI. So we work together. We can provide stuff to them, data and patient tracking, and they can provide some really interesting testing. I've seen them do some pretty crazy and very cool tests.
We're at a really unique intersect between public health and medical care. And so we're really lucky in Georgia. We have a great relationship with our public health department and are able to do similar things to this and have a good working relationship. But I think part of that comes from having toxicologists that are willing to get out there and work with those folks. So yeah, I think this is a great case and a great, like you said, way to show that these two entities can work together.
I kind of want to just jump in here to provide a huge pat on the back to one of our faculty, Dr. Justin Corcoran, who's been on the show because in 2020, Dr. Corcoran published Fatal Yellow Oleander Poisoning Masquerading as Benign Candlenut Ingestion Taken for Weight Loss. And lo and behold, 3 years later, across the United States, the Maryland group was confronted with somebody who has a pretty clear toxidrome for a cardiac glycoside. And a quick search found this case report, and I do believe that was the impetus of them getting authorities involved to actually test the product. So this abstract to me is a testament to what you can do with a case report. Even if you think something's like not all that exciting, just put it out there because it might be the first thing of many things to come. And then, so I don't think the health department in the state where this was initially identified wanted to carry it forward, but it doesn't mean that it won't be the impetus of a different health department, which I guess with different priorities. So that's why I love this one.
Yeah, it does worry me to think what else. You know, this is just something we found, or something that the authors were able to find had this product in it. How many times has this product been purchased by who? Is there quality control being performed on all the other products? I mean, like, if one of my family members or friends or literally a random person on the street said, hey, like, is this worth taking? It might cause weight loss or it might kill you. I think we would all say probably not worth taking, right? I wouldn't take that. And so it's concerning. I wonder if this is still out there. I don't know. It's terrifying.
I mean, how much weight loss? How much weight loss am I getting? All right. Well, I think that was a great abstract. Anybody else have any thoughts they wanted to bring up on that?
That's incredible clinical care that they gave. I mean, they saw a person who was bradycardic hyperkalemic in the setting of some weird ingestion and quickly thought to send a DIG concentration. I think there's a lot of places that doesn't happen really expeditiously. So they either knew their literature or they knew their tox differential pretty quickly, and the person got outstanding care. So it's a cool case.
Fantastic. Thank you for bringing that one up, Dr. Trebach. Dr. Kiernan, would you like to jump in with yours?
Yeah, sure.
Abstract number 2. Efficacy of sodium tetrathionate when administered intramuscularly for the treatment of acute oral cyanide toxicity in a swine model.
So my interesting case is a little bit different. This is actually dealing with cyanide and poisoning swine. So don't let all the PETA folks come after me. This is under the FDA animal rules, so we're okay. But I think that this is an important one because a lot of people, and even in just talking to my residents, you say cyanide and people think like, oh, don't drink the Kool-Aid or, taking a poison pill or poisoning your significant other, or whatever it is. And again, like we know that there are antidotes for cyanide that we've been around forever. We have the cyanide antidote kit, and then hydroxycobalamin is kind of our gold standard right now. But one of the things I think people don't think about is that that's going to be for like a one-time acute ingestion or acute gas exposure. But that might not be what we're dealing with. And again, pretty scary to think, but cyanide is actually a pretty significant chemical terrorism threat. And not even that long ago, if you think back to kind of Osama bin Laden planning to poison salad bars and food supplies, and then ISIS a couple years later also kind of advising people to attack or inject food in markets with cyanide. So like this is particularly scary because it would be very quickly lethal, could easily lead to a mass casualty and go fairly unnoticed for a while, and could potentially have a lot of people having to be treated very quickly. And so the current regimens that we have, right, like you need an IV. If you're giving hydroxycobalamin, it's not a large volume, but larger. Like you have to get an IV and give it through the IV. And so we don't, like, our antidotes are fine. It's going to be a limited resource, and they are for a very particular type of person. So if we have a mass casualty, if we're talking with our military folks, people that might be out in the field, or our first responders, EMS, those antidotes might not be the most ideal thing. So the study was evaluating the efficacy of intramuscular administration of this antidote, sodium tetrathionate, in swine. And after the swine were given oral cyanide, and to analyze their survival compared to untreated swine. This group of toxicologists, authors, and institutions have really done some really important and significant work in this kind of antidote setting, from mice studies to rabbits, and also in large animal, these Yorkshire swine, which also felt appropriate because it's like Christmas themed NACCT abstract review, so Yorkshire swine. So they were given... They were randomized into either getting no treatment or an IM sodium thionate treated group, and all the swine were poisoned with oral cyanide. And so at 120 minutes, the outcomes were either death or not dead. And at 120 minutes, 100% survival in the treatment group versus 0% in the control group. And again, so definitely some limitations here, but showing again that they're working on these antidotes that potentially, if you have an IM, like an auto injector or something, if you have a mass casualty oral ingestion, that this might be something that's a possibility. And I know the military folks are kind of looking into this and trying to identify the best ways to potentially roll this out in the future. So I think they're doing a lot of really good work kind of behind the scenes. And it's not ready for prime time yet, but they're definitely making really large steps. And again, sort of just highlights also that toxicologists really have this role in antidote development and public health and CBRN, disaster preparedness and management. And it's just another really cool thing that we do.
It wouldn't be an NACCT without reading about a cyanide antidote that I still don't have access to, and an acetaminophen test that I still can't order.
But one day when it's there, you're gonna feel left out at NACCT. Something's gonna be missing. So.
I think it's awesome. It's so cool. And here's what's really cool about NACCT is I learn about a new antidote every year. And they're always developing them. I just want them to bring them to market. So yeah, and I am thrilled that the DoD is, I guess they're really concerned about mass cyanide exposure, but somebody should be. So that is good. I like that.
Someone should be. There's too much Kool-Aid in the world.
Whenever anyone brings up the Kool-Aid, there is one toxicologist, always, no matter where they are. The closest one, usually within a 50-mile radius, has to come over really quickly and say, actually, I think you mean Flavor Aid.
Yeah. Yeah.
Thanks for being that toxicologist.
Two things, my perspective. One, all those episodes, particularly in Japan with that cult, the ones that did the sarin gas attack. I don't know how to pronounce the name. Ryukyo or something. Every time we try to do mass poisonings with agents like cyanide, they can be given as a gas or in other modalities, water, you either can't get the concentrations you need, or people fall over and they run away and you get trauma victims. And I was alive and an adult when the Tylenol murders happened in Chicago. The other really good one would be the New Stockholm church poisoning, where a bunch of elderly people died from cyanide. And really, the numbers are not gigantic, and the money that would be spent on supplying everybody in the military with this. And then you have to talk about, I don't know, were they going for 10 ml because that was a restriction for intramuscular injections in humans, which is sort of true, but not entirely true.
If you have not actually read the abstract, Frank is referring to the fact that the intramuscular doses given to these pigs were 10 milliliters in volume.
Or was it for the dose? Because 45 to 50 kilo pigs are not my patients. I'm looking at 25 to 45 mil IM injections. So, it's not a bad idea. I'm glad they're doing it. Something would be nice to have someday if we happen to be there. The second said, the person walked into triage and said, I'm swallowing cyanide right now. But to me, it was meh.
I mean, if I had to choose between having 2 PAM in all of my CDC stockpiles or this, I think I would go with this. I mean, we already have 2 PAM everywhere. Why not add in another antidote that has at least decent?
I will say that I am like Ryan. I always get excited when I see these like new antidotes. I feel like it's like hearing about like a movie that's going to come out like 10 years and you like wait for it. And then you find out that like, that one of the actors quit. And then like I don't know, it somehow fell under, or they're still filming. And you're like, what did I hear about this movie coming out? I thought I did. And so I hope this doesn't fall into the similar sort of stuff. I feel like this has potential to be quite interesting, but I guess we'll have to see if the movie comes out.
Where's cobinamide? I've been waiting for cobinamide to come out. This is the sequel to cobinamide, and the primary hasn't come out yet. I mean, it brings up great points. IM is probably the route for mass casualty, not IV, which is all we have available. But I'm curious, does this work the same way? Or is this one where it's going to bind and create thiocyanate? For cyanide detoxification, so you can give hydroxycobalamin, which is what we do right now. We give it IV, binds the cyanide, and makes cyanocobalamin. Or cobinamide, the IM injection, that can actually bind multiple cyanide molecules as opposed to one. And then there's sodium thiosulfate, which creates thiocyanate and then you urinate out. And there's a whole bunch of conflicting literature if that even really helps eliminate cyanide, as opposed to cobinamide binds and creates.
I think it's the thiol groups. It's just it's making thiocyanate.
Yeah, so that's what's interesting is like sodium thiosulfate doesn't work as well as hydroxycobalamin does to make.
These 4 pigs would disagree.
Well, these guys didn't have a cobinamide comparator. So that's what's really interesting. This one is great in that it showed it does prevent death, but would it do so more so than hydroxycobalamin? Or maybe that'll be in the next writer's room for this movie coming out. Thank you for sharing that, Dr. Kiernan. I appreciate that you are always not only forward thinking, but concerned about the bioterror health of the population.
Thanks, Ryan.
Dr. Comstock, would you like to roll in with our next abstract?
Let's do it.
Abstract number 10. Is Aranaf after out-of-hospital naloxone for opioid overdose? Prospective preliminary data from real-world implementation of the modified St. Paul's early discharge rule.
Hey everybody, it's Ryan, and I am interrupting just to provide a little bit of background on what the hour rule, or the St. Paul's early discharge criteria, is that this study was evaluating. Dr. Comstock is really going to dive into the specifics, but if you haven't heard of what this rule is, it's basically a clinical decision rule to decide if a person is ready to go home after they were given naloxone for an opioid overdose, right? If you've overdosed on opioids, we can reverse that with naloxone, but that naloxone can actually wear off. So the clinical conundrum of a patient who received naloxone from EMS shows up to the emergency department and looks totally fine. Can they go home? Well, some people would wait 5 to 6 hours to ensure the naloxone is totally out of their system before saying, oh, you'll be okay. And others would try to develop tools like the hour rule to determine who might be okay for discharging early. Okay, back to Dr. Comstock.
So I chose, if I can find it, abstract number 10 from Stephen Douglas and some Minnesotans. And I chose this article because not necessarily this project, but many of its predecessors get brought up on shift in the emergency department by residents who say, we need to watch this patient for X amount of time. They'll either quote the St. Paul early discharge rule, or they'll quote the hours study, and they'll say, that's why I'm choosing blank. And we walk through the data, we walk through the limitations of those data, we walk through the fact that that was a different era and how perhaps it's time for some new data. So I was excited to see somebody taking on the charge of gleaning some new data in what is very clearly a very different drug market than was around when a lot of those earlier decision rules came around. If you think back to the hour trial and before, a lot of those overdoses were heroin. Obviously, that's a very different world now where we've got fentanyl abounding, as well as a lot of the other novel psychoactive things that are existing in our drug market, to include xylazine, nitazines, long-acting weird benzodiazepines, you name it. It's a weird world. And so does a non-weird decision rule still apply? Did it ever apply? I don't know. But does it apply now? And so that was the question they're asking. So they looked at patients who had received naloxone, and they looked at them an hour after they had gotten their naloxone for whether or not they had met the hour criteria. And they also looked at whether clinician gestalt said that these patients were safe for discharge. And as a quick reminder, the hour criteria is not just like, are you good to go after an hour? It's a set of 6 objective-ish criteria that you can utilize with a bunch of yes/no boxes to say this patient's good to go. Those 6 criteria are: they can mobilize as usual, they have a normal oxygen sat, normal respiratory rate between 10 and 20, normal temperature, normal heart rate, and they have a GCS of 15. And so if you check all those boxes, then these patients can go home. And as a quick reminder, with the hour trial that came out now, I don't know, 6 or 7 years ago, it was deemed to be sensitive-ish. It had a sensitivity in the mid-80s, and their authors kind of concluded that, yes, maybe this is helpful, but a lot of people have looked at it and said, look, mid-80s sensitivity for potentially needing additional naloxone is probably not sensitive enough. And so it was maybe put on the back burner for a lot of folks clinically, but still gets brought up quite a bit in the emergency department. So for the outcome in this study, and again, this is a preliminary look at their data. This is not the end. So they're still, I think they're still actively enrolling patients into this prospective study. But they enrolled 220 patients, because about half of them had received their naloxone intravenously. Another about a quarter had gotten naloxone from bystanders, so intranasal. And ultimately, 41 out of the 220 met the hour criteria. And of those 41 patients, only one had an adverse event. Now, it's a really weird case. So this patient meant to insufflate cocaine. After that event, they became unresponsive. They got 3 doses of intramuscular naloxone and 3 minutes of CPR. And it's hard to understand how somebody thought this patient would have been good to go after an hour, but that's what happened. But they realized that the patient was supposed to have gotten an x-ray. They then ordered the x-ray, and while awaiting their x-ray, they became hypoxic. They needed additional doses and eventually an infusion of naloxone, I think for about 7 hours, and eventually discharged from the hospital, neuro intact and doing just fine. I think they said about 18 hours later. So a couple of thoughts. So first major thought I have is it's documented in some of the prior trials how these patients are using. They document whether they're insufflating, injecting, or they're taking enterally. And they do document that patient who did fail the hour criteria, he had insufflated. But it'd be really interesting to know whether or not they have the data about how these patients were using. Because frankly, I wouldn't even try to apply something like this in a patient who's using their opioid enterally, with the concern for longer duration of absorption and a greater risk for delayed respiratory depression. And then the other thought I have is their follow-up data. So they list that they have follow-up data on 28 out of these 41 patients who met the hour criteria. And then they say, in general, we're pretty confident these other patients did just fine because they're not dead in their EMR review. And that feels like a bit of a leap of faith to me to say, like, yeah, I glanced in Epic and I didn't get that really sad like alert that comes up that says, sorry, you're entering the chart of a deceased patient. Do you still want to proceed? And you say, yeah, I guess so. Like that's what they're using to say these patients are not having adverse events. So this feels a little flimsy to me. I'd say really they only have follow-up data on 28 patients who they could get in touch with on the phone the next day. And so I think their denominator is actually incorrect in this. And I think they probably need to revisit that number. So I think they're documenting a 2-ish% failure rate. I think even they in their conclusion say that's probably not good enough. So I say kudos to them. I think they're very well interpreting their data correctly, but I'd say I'm not sure I agree with them on the denominator. And so when I look at this, I think, certainly I didn't use the St. Paul early discharge rule already, and I will continue to not use it. It's probably a helpful set of kind of reminders of what makes a patient a normal-ish looking patient. If they can walk, if they can drink, if their vital signs are normal, then they're probably okay to go. But I think to lean real heavily into these decision rules for something that's a pretty it's a decision with a lot of gravity attached to it. When you think about development of recurrent opioid toxicity, I certainly don't think the application of these decision rules is for me necessarily.
I agree. You said it exactly well. I think when I was reading this, I was like, I was going to be disappointed if the conclusions were the opposite of what they had said. If they were like, that's actually a pretty acceptable, miss rate. I was like, no, that is not, in my opinion, especially not for this. I thought your evaluation was really very consistent with my own. So I don't think I have too much more to add. But
I was just going to say, you said it exactly as eloquently as I was going to say it.
Yeah, no.
I think you bring up a great point in that when we looked at heroin and how much naloxone was needed for heroin, a lot of the denominators in those were medical examiner data showing, hey, this was treat and release from paramedic data, where if a paramedic gives someone naloxone, do they even need to go to the ER back in the heroin days? But the heroin's not around anymore. I mean, it is. Heroin's there, but the rate of resedation is maybe one of the few signals we are seeing in how the opioid landscape is changing in some of these really high potency or highly lipophilic substances. So
one of the reasons I brought it up is, during the presentation of this at NACCT, it got a lot of real excited comments. And so I think there's a lot of people who are looking for this to go into prime time. I'm pumping the brakes as it stands with the abstract, and I will probably continue to pump the brakes even with the final papers out.
I couldn't agree more.
I'm honestly surprised amongst toxicologists that, especially with the way we're going and all of the data we're getting with with naloxone and opioid use disorder and overdoses, that everyone was more on board with this. I could see kind of what we're saying, like the ER doctors, trying to get our dispo, trying to get people out the door, trying to be more on board with this. But it's shocking that at the conference, people were more excited about this.
What's wild is that people are still using the hour criteria, even though it had an 85% sensitivity. It's kind of wild that we're using it to begin with. It's honestly better with the data they got, but
I don't like the rule. Not nowadays.
I was trained initially to, we'd watch all these folks for 6 hours, which I think is also as inane and arbitrary as anything else. And I don't think they all necessarily need that, but I just think this is an area where there's probably not a nice standardized replacement for clinician gestalt, unfortunately.
That at least has some mechanistic rationale. You're waiting for naloxone, giving your half-lives a good chance to eliminate all of it. But I agree, it's great points to bring up. Since we're at the halfway point, I think it's time for a few honorable mentions. Before we go into any more, I believe, Dr. Kiernan, you brought this one up, number 140. Poster titles at the North American Congress of Clinical Toxicology 2013 to 2022. Is NACCT experiencing a pun-demic? I actually felt like this was taking aim at you.
Actually, full disclosure, I reviewed this abstract when I was when I was a NACCT abstract reviewer, and I gave him a pun back to it, and he called me out on it.
This was basically just a review of all the poster titles and how many of them contained punny wordplay within them. And it actually seems like 2023 was the punniest year of all time. The rates of puns in poster titles has been increasing literally every single year. I personally believe this is largely driven by Minnesota, as well as a few other groups.
I'd like to point out that two of the first two authors on that are trained in Atlanta.
This
Dr.
is true.
And Dr. Elizabeth Stover. So I think Atlanta is part of the problem.
This is impressive. I remember one of the Illinois group's abstract about carbon monoxide poisoning from boat motors was carbon monoxide is something to talk about. So I think they're a contributor as well. I am actually, and I'll take the heat for this. I am anti-pun in the title. You can put it like in the actual thing, but if I'm doing like a systematic review and I have to interpret a riddle to figure out what the paper is about,
I don't know. It depends. I feel like I don't know if it's the toxicology field as a whole or not. Like, what are the dermatologists doing in their papers, or like what are the pathologists or what are the cardiologists doing? Because I remember when I was a fellow, I wrote up a paper and one of our faculty was like, "Oh, you got to make it like a super cute pun title, whatever." And I was like, "Oh yeah, sure." So I did that and submitted it, and it immediately got rejected. And they were like, "Please refrain from using cute or puns in titles." And I was like, "Come on, man!" I was like, "I'm just doing what I'm told." So I don't know. Is it a tox thing? Like, is this we need to have this needs to be discussed at our next meeting?
I think this is a positive trend. I think we are one of the worst dressed and nerdiest of all the specialties. And so the opportunity to add a little bit of levity into the titles that are otherwise not blank, 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 colon, blank, 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 question mark, which is exactly what this title is. Otherwise, the pun in there, it's a welcome change. I look forward to more.
Dr. Kiernan, I know you are the highest pun utilizer I've ever met.
Thank you.
Are you a pun user in your titles?
I am. And I want to make sure that you're okay. I mean, are you feeling okay? The fact that you are getting angry about people putting puns in their titles makes me worry about your wellness a little bit.
Fun. And no, I'm not anti-fun. I'm pro pun in some scenarios. I like when we sneak puns in. I don't like them so overt. I tried to write a paper about vasopressors, and you know how everyone does those cool abbreviations? We came up with a really out of this world name for the title. Also, we could spell out Vin Diesel in the title, and I ended up not getting accepted with that title, which was a little annoying. But all right, well, thank you for that sidetrack. That was everyone is allowed to pun. You're making me turn my mind around a little bit.
Ryan just wants everyone to send him their titles before publishing or submitting any future abstracts. Is that correct, Ryan?
Yeah, that was the appropriate interpretation.
Yeah. Okay. Good.
If you are ever thinking about doing anything, please send me the title of it for my approval. Okay. The next abstract that we were going to talk about was a rivastigmine abstract, but Dr. Paloucek joined us at the last minute, so I was going to assign him a random rivastigmine abstract, but knowing his high standard for research abstract, I'm not sure I want him to present one that he did not choose himself, as I don't want any authors or abstracts getting dragged through the mud without their ability to rebuttal.
So no dragging the random authors on the papers.
Yeah. Well, at my advanced age, it gets harder.
We can point out limitations. There's been a ton of abstracts at NACCT this year on using it for anticholinergic delirium. This is huge now. Pfizer's been out, and I'm just curious what all of your takes are. Dr. Paloucek.
I have not found the need to jump on physostigmine as commonly as some other poison centers and people have, and to use it as often. Rivastigmine offers some mild advantages. Everyone seems to love this. Everyone's doing it in my world, EM pharmacy, and I just no. And I need you guys to tell me I don't know what I'm talking about.
You're anti-rivastigmine? Is this what we're getting here? You were of the days of Pfizo. You've probably given more Pfizo than most people in this room because it's been
Well,
expired.
no, I only gave it once in my life back then.
Really?
That was for a plant. No, I'm not I am not anti-physostigmine. I'm not anti-rivastigmine. I am anti the sudden popularity of a new antidote or a new anecdotal therapy and everybody using it all the time whenever they can, and they do it thoughtlessly.
Are you talking about flumetazole?
Boo.
I didn't say flumetazole. You want to talk about flumetazole? I thought you were
Kidding.
I like flumetazole, but that's different than just being an antidote. I'm in the small camp of people that thinks it's adjunctive therapy that promotes hepatic regeneration.
All right. We're not going into flumetazole.
Well, you open the door.
I know. Okay.
I'm not anti-Pfizo, anti-rivastigmine, anti-cholinergic, any of those things. But I mean, putting on the transdermal, at least in some of the steady state data that I've seen and looking back in the Alzheimer's literature and other places that they use this, I think that people had similar efficacy to the pill, but also had higher nausea and vomiting, which isn't really something that I want in my really delirious patients. And I'm also I love giving Pfizo. It's a fun party trick, especially when you have EM residents that have never seen an anticholinergic patient, then you wake them up and they go back down. But in reality, does it really change a whole lot of your management time-wise? Just playing devil's advocate. I agree. Do we need to be jumping in and giving this to everyone? Or should we really just let them be a little anticholinergic and hang out until they metabolize their drug and treat them with benzos like we do with everything else?
Yeah, Emily, I agree with you. I think when I was in fellowship, the people who trained me would always say that physostigmine has never saved anybody's life. And I would agree with that. I feel like it probably reduces a lot of the agitation. And, if someone's going to get themselves into trouble from being anticholinergic, it's either the agitation, the muscle breakdown, they're getting too toasty or hyperthermic. I probably should use my doctor words. So I agree with Emily and Frank. Just throwing the patch at people who have who just look anticholinergic might not be the best approach. I think there is a role for this, especially given the Pfizer shortage that we find ourselves in. I don't think it's something that should be abandoned completely, but I think picking it up is being this is the cool new thing to do. If you have dilated pupils after taking diphenhydramine, you get a rivastigmine patch, right? That's not the way to go.
I think there's a world in which Riva is a cool add-on to this patient population, where you've got the person who's sitting delirious after their big diphenhydramine overdose. They're stuck getting a bunch of benzos or whatever for days and days, and then eventually they come around and they do just fine, the way all these patients do. Is there a way in which this patient can be mobilized to psychiatry earlier, where you give them a pill, you slap a patch, and they still have the patch and they're still getting a cholinergic medication? And if they have reached a point of not being super duper delirious and their vitals are fine, they can just go to psych with a patch on. And that's, to me, where I would see the ultimate benefit of Riva, which is a benefit that Pfizer doesn't offer. You can't send somebody on a Pfizer infusion to psychiatry. So I think there's a world in which I think Riva's actually got the potential for benefit over Pfizer.
But no psych patient, whoever is feeling really anticholinergic and good, would take off that patch midway through their psych hospitalization.
Take the restraints off, but leave the mitts on. Leave the mitts on.
Yeah.
So, yeah, I agree. Efficacy, there's probably lots of questions. There are probably still questions with Pfizo's efficacy, and that has a lot more data. Riva is another avenue here. And I do think all of these case reports and case series that are coming out in the NACCT abstracts every year do provide at least one useful thing. And that's, if you're about to recommend this, you probably want to know if anybody has died or had some serious adverse effect. And I have not read in any of these abstracts or any of the case series. Some in this year, we had case series as large as 30 people who got rivastigmine. I know I've read some papers published in JMT with at least 30 people who got rivastigmine, and nobody seems to be dying or really having any described adverse effects. Now, it's not exactly pharmacovigilance data, and I don't know how many doses of physostigmine were given before we saw those 2 cases of asystole, temporally associated with severe TCA overdose. But I mean, it just in theory, seems like the safety profile of rivastigmine is actually better. I'm not giving an IV drug. Are we going to start seeing people have seizures or something later? That's possible. So far, it doesn't appear to be harming anyone, and I think that's at least useful data. When and how to use it, that's a whole other story. I am more curious about when are these patches getting removed and what are the effects afterward?
Yeah,
sure.
Okay. I think that brings us back to the top of the round robin, which is me, I believe. And this is going to be a really quick one.
Abstract number 5 randomized human trial of a NAB001, CB1 receptor antagonist, in 3 doses of cannabis.
This is first author Andrew Monty, done by the RMPDS group. I know a couple people from there. Interesting folks. And I'm going to summarize this real quick for y'all. They made a naloxone for weed, everybody. We're going to save the U.S. But honestly, this is fascinating. So this is actually a CB1 receptor antagonist, right? And that is where delta-9 THC works. That is where all those little kids who just ate a massive bag of weed Oreos and are now sitting in whatever medical floor or ICU, that's the receptor that's being agonized there. So wouldn't it be amazing if we could just hit them with a CB1 receptor antagonist and let them go sit at home or somewhere else? So that's kind of where I see the future benefit of this. If we're going to put things into sections, this is under antidotes I still don't have access to, but it's a pretty interesting study. So randomized, double-blind, placebo-controlled trial. So it was a dose escalation of both THC and the antagonist, which is ANAB001. It was done in the Netherlands in like a closed unit, kind of interesting. Experienced cannabis users got a couple of different doses of THC. They could have gotten 10.5. In another part of the study, they could have gotten all the way up to 40 milligrams of THC. And then they were given it with 50 milligrams of ANAB001 or 100 milligrams of ANAB001. And then they also did a few other cohorts where they actually gave the THC and then gave the antidote an hour later. And then they just assessed their outcomes using visual analog scales, as well as a few other scales for basically, in layman's terms, assessing how high you are. What they found here was, unsurprisingly, ANAB001 was well tolerated and rapidly reversed the effects of THC. It reversed it whether you gave it at the exact same time as THC or if you waited an hour and then gave the reversal agent. So I see this having massive utility because in the American Poison Center's annual report last year, for the first time ever, showed that THC gummies surpassed plant-based marijuana for exposures reported to U.S. poison centers, and that was driven almost entirely by little toddlers gobbling up weed gummies. So there is a huge burden in healthcare of kids sitting in children's hospital beds, sometimes for days, because they're taking actually pretty big doses, sometimes getting into whole bags of gummies and just being kind of too sedated to go home. If we're talking about real exposures that we need an antidote for, this would be a big one. This is like developing an antidote for alcohol. I see a lot of TikTok influencers saying they have that. Not a real thing. This could be a real thing, but I don't know how long this lasts. I don't know how it deals with someone who ate an entire bag of weed Doritos. I have lots of questions. What do you guys think?
I think it's super interesting, and I agree completely. I would love to see this specifically for a pediatric population, because I think those are the people we've seen the most. Certainly, I've seen the most morbidity with respect to these gummies. Because I'll be honest, when I was a kid, like I 100% would eat like floor candy or any sort of gummies or whatever I could find. And so it's not a surprise that we're seeing kids get into a lot of these products. And what's particularly challenging with these, THC, these cannabinoid gummies, is that as we've seen kids get super duper, they can get super duper sick, sometimes like bradycardias and apneas. And even worse is that even if like that's with the history that they've taken one of the gummies, but sometimes we see these kids come in and no one knows what happened. And so they end up getting an EEG and an MRI, but then since they're like, very little, they have to be intubated for it and this whole thing. And then they're up in the ICU. And so it's a lot of healthcare resources too, when it would be wonderful if there was just a reversal agent that could be given. So I am super excited to see what the future holds for this. Hopefully there aren't any untoward effects that happen in the pediatric population when this is used in particular. And I guess, I'm not saying adults don't deserve to have an antidotal therapy available to them as well. But if I had to pick a patient population where I'm seeing more morbidity, I would say definitely eager to see what happens with this with respect to the pediatric population.
Interesting, but I mean, we need to see, does it work in people? who are sick. You're going to have trouble getting the FDA to approve this product because of concerns about it being used in or having a company bring it into the U.S. Kind of like there was issues with flumazenil when it first came out, in terms of it facilitating alcohol abuse or other drug abuse, where people would just take the antidote and then feel they were safe to drive, go drive and come back. I mean, you may or may not know, but the original name for flumazenil was Versed because it was made by the same company as Versed, and it was supposed to be, but their legal department said we were part of the original trials for indiscriminate overdoses. Their legal said, no, there's the risk management there is too high that people will use it to drive. We can't afford insurance costs there.
Interesting.
I think they gave people enough to test the high. and so the visual analog scale and all that is fine, but they didn't actually they couldn't, I suppose, give them enough to make sure that there was actual symptoms to reverse. And so we don't know the symptom reversing doses, and we don't know their safety yet. That this is a proof of concept. It's a good place to start.
Yeah, it's an appetizer. I'm looking forward to more.
Yeah.
Because right now it doesn't apply to the patient population that I would want to see it in, just like everybody else here said. And I think one of the comments that was made at NACCT is you're out at the concert, you smoke a joint too many and you want to be able to get home. You just pop in one of these pills and you're good to rock or good to go. So I think there's going to be a lot of interest. If it works as well as it looks in this abstract, it looks like it works great. There's going to be a lot of interest in using this in not just the really sick toddler who got into mom and dad's gummies. I think just, to Frank's point, there's going to be people who want to use this for all sorts of other things. And I don't think that's wrong if it works and is safe, but it's not close to being there. And so it'll be really fascinating to watch as this goes forward, see where it goes and who wants to get a hold of it.
Right. I assume this would come out as prescription only initially, although
sure.
that doesn't necessarily mean people aren't just going to get it from other sources. And
also, you look at, drugs like Ozempic, but there is a proper indication, and then if people want it, they will find it and get it, whether they indication or not. So
indication creep. Your concierge medicine doctor is going to give you Ozempic and then the THC reversal agent, so you can
living your best life.
What if you just put the Ozempic and the THC reversal agent in a product called Indian Nuts for weight loss?
Hey.
Can the company be called Indication Creep?
Ooh.
Oh, yeah. That might be a band.
I like this.
Fantastic. Well, I just think, it's interesting. I do worry about cyanide, exposures throughout the U.S. and having antidotes for that. But there's also a whole bunch of kids in beds, too high from eating weed gummies. This could be an interesting
That's a bigger
thing.
Concern. Yeah.
Okay. Who's up next? Oh, look at this. So for the audience, you can't see, but I'm sharing an image. I'm sharing the PDF, and we just talked about abstract number 5, and then abstract number 6 is another great one: alcohol-related recidivism following emergency department-associated naltrexone. Dr. Grant Comstock, which we're not talking about today because we decided it wasn't important enough. Sorry.
Mercilessly excluded from the discussion. You guys are haters.
I do want to point out that everyone on this, minus maybe Frank, did some amazing research this year. So please peruse the abstracts. And Frank has already done a lot of amazing research and written a lot of books, so he doesn't have to do it anymore. But
I'm just not publishing what I'm doing in my neighborhood. That's all.
You feel free to peruse, and everyone should be checking out the abstract and the PDF where for every one of these 360 abstracts, as I'm sure I'm going to mention in the beginning of the show, is available at clintox.org under NACCT. You can find a free PDF there. Okay. Who's up next? I think we went Dr. Trebach next.
I think it's me. Yeah. It's timely after our talk about rivastigmine. This is
abstract number 216. Successful use of expired physostigmine to treat anticholinergic delirium in a pediatric patient.
I thought this was a cute little abstract because I enjoy when people put stuff out there that we think is that a lot of people should know / already know already. And so this is number 216, successful use of expired physostigmine to treat anticholinergic delirium in a pediatric patient. I know some of the authors on this. They're all cool people. So what this paper, this abstract describes is, we know that we are in the United States right now going through a FISO dilemma right now because our sole distributor, the manufacturer, the pharmaceutical company, stopped making it, and they closed permanently. And so a lot of physostigmine that people still have is either not existent, or it probably expired in like 2021. And so the question is, can we still use this? And I think this is something that I feel like people do call the Poison Control Center, not just for like FISO, but just expired drugs in general. Like whether this is a home call, like, oh, I took an amoxicillin that expired last year, is this safe? Or I'm pretty sure when I went home to visit my family, there was like a acetaminophen from like the 90s or something. Clearly it had been expired. So these questions come in. But so this paper describes can we still use an expired medication? And is this a potential avenue we can pursue if people didn't want to do a rivastigmine patch or weren't on team patch and wanted to go down using their FISO? So this case report abstract describes a 16-year-old patient who came to the emergency department after ingesting a bunch of medications, sertraline, cyclobenzaprine, oxycodone, prochlorperazine. And their physical exam was what they described as a mixed serotonergic and anticholinergic. The patient had delirium, dry mucous membranes, non-reactive mydriasis, tachycardia, and then some clonus as well. So I can see how they had come to that conclusion. It sounds like the patient received benzodiazepines and then received the expired physostigmine twice and was able to interact with her family and was significantly improved supposedly afterwards. And so I think the reason this caught my eyes because I think if I had done this / have I given medications that have been expired but are still indicated and we have no other choice? Yes, I've been in that situation before. But have I ever thought to publish it? I don't think so. And so I'm glad that people did, because oftentimes if I wanted to give a medication, for example, that was expired, I can think of previous institutions where I've worked at where it doesn't matter what I want. If it's expired, I'm not getting it, right? And so it's nice to be able to bring up an abstract or something that is put in a publication that says, hey, look, like you can do this and people can, they're not going to explode because they received a medication that expired, right? And so I know that, especially in the world of toxicology, where we have our, quote, antidotes or some of our rarer medications that aren't really given as often, this is something we have to consider. And so I'm just curious if anyone else has any other thoughts or has run into the trouble that comes with giving expired medications or in scenarios like this.
We just had a kid who's a pediatric lead, and Suxamur is on shortage. And so same thing, the only Suxamur that we really had available is expired. But again, sometimes, what really is an expired medication? Because all of the studies that they do, right, it's just looking at like when the product is supposed to, or how long it's supposed to remain stable and retain like the exact strength that they tested up until that day. But, if you take it on day 100 and it expired, or day 101 and expired at day 100, like, does it really change the efficacy?
Well, then you die. Then you die immediately.
Yeah, you explode, I believe.
I know. Someone from Team Patch would say that.
They have to state that it's expired if it's degraded more than 95% of the labeled amount, but they can date it earlier than that if they like. They only test for so long, then they dated that. They could have tested further. So it's to save money and maybe make money by promoting renewed sales. There was a paper many, many years ago published out of the Pittsburgh Poison Center, Ed Krenzlock and his group, where they please give whatever Ipecac you have in your house to your pediatric child who just swallowed that dangerous thing. And they were able to identify that Ipecac that was 17 years past expiration date was still pharmacologically active and elicited the appropriate response. And there was a bunker in Germany from World War II where German medical supplies were found, including atropine to treat, you may have seen this ad, atropine to treat gas poisonings. And that thing buried underground for 45 years still had pharmacologic potency. So yeah. I think, I don't know what you all do. We don't routinely use expired meds unless we're forced to, sort of like the lead case, Emily, you were just describing. But my colleague and I in the ED, any med that we think we are likely to have shortages with or high criticality, low use, we, with the cooperation of our storage tech, perhaps hide expired vials. Not that that would ever be admitted, and never would that be found anywhere in the hospital. But since the College of Pharmacy is 15 feet away from the hospital, perhaps in somebody's office, should there ever be a mass epidemic. And I think that's a situation where it's likely to occur. Expired meds were used in New Orleans during Katrina. If you haven't heard that, it was all word of mouth, but it was done. And when you have that kind of setting, I have no hesitation at doing it. The worst I risk is it won't work, or I have to give more.
This is a good infrastructure for the U.S. in severe need. Is you gotta raid pharmacy professor offices, and
no, you have to have hired a pharmacist who works in the ED who would have the common sense to do this sort of thing.
I mean, we hold expired stuff all the time because we know, like, the FDA will eventually post date it and they'll say, yeah, you can use it. We tested this batch. And we've given expired drugs. Sometimes you have antivenom from a zoo, and they're like, I'm only sending you my expired stuff. And you're like, well, I can't tell you what to send me, and I'm not going to, you say you got to give it if their patient is having symptoms. There's only been one thing that I know of where giving an expired drug potentially caused harm, and that was, and we don't even know for sure, and it was tetracyclines and, Fanconi syndrome, and that was a long time ago. I will say IV makes me more nervous than oral, but even then, I'm really not concerned. So this IV physostigmine is really interesting. There was a study also of naloxone that was on ambulances since 1980, and it was like they tested it all, and it was all completely fine. So it turns out drugs are super stable, guys. We don't have to worry about it. Why are we even bothered?
I think it's the word expired carries a lot of weight there, because if someone was like, would you eat this expired burrito? I'd be like, probably not. But if someone, do you want this expired? Well, I guess it depends how hungry I am.
You already admitted you were a floor candy person.
Dang it. I've said too much about myself. But like expired medication doesn't cause the same level of repulsiveness that when we use expired to talk about other things like food, for example, that sounds bad and dangerous to like eat expired food or something. But like expired, medications, I don't know. It's just a word I think that sometimes can cause people to be concerned when really there's not really been, aside from the tetracyclines and possible Fanconi, but I can't think of anything else really.
Well, we do hold ourselves to a high level of regulation in the United States, whether it's good or bad. I mean, it is one of the good things where when you get a drug, you know what you're getting. And I think that's good. But when we run out of that ability, well, at least for prescription drugs, when you run out of that option, sometimes you have to come up with other things. I do believe I talked to the lead author here, Brian Hayes, who a lot of people probably know of as a noted EM pharmacist. And I believe they had ethics involved in this decision, which I don't know how I could functionally operationalize getting ethics involved in an ED.
Well, how did ethics approve it then? I'm sorry, I like Brian, but I don't understand how in this patient, the decision to give a total of 2 milligrams of lorazepam, 45, and the two are separated, 1 milligram, 45 minutes apart, that warranted using the physostigmine was given enough. That somewhere along here, they thought they could go with the expired. I don't think anywhere do I read in this case report that they hit some kind of commonly accepted benzodiazepine dosing limit.
Well, some people are of the stance that benzos are not the preferred in this scenario. There is good data. There's a randomized control trial that shows that patients.
Next meeting we're at, you and I can sit at a table and talk about that paper.
We're dancing. The one out of Colorado, they showed that it was a little bit better for actually managing their delirium mechanistically. I know. I'm just saying. I could see. I'm just playing a little devil's advocate. I could see where they're coming from.
Yeah,
but it is interesting.
Am I the only one that got an email from the FDA saying that there was a temporary importation of Pfizo?
No. We're already getting it.
Right?
It's coming.
Keep talking about it like it's this ghost, but I mean, it's making a comeback. Yeah,
it's a comeback because you all are demanding it. Ugh. Sorry.
Hey, let's say it could. So there is data that shows there's less ICU admission when you use this.
It was retrospective, so uncontrolled.
Yeah, I know. I love uncontrolled data. It lets me confirm all my biases without ever having to really do a deep dive into what I think.
If you were anticholinergic, would you rather have benzos or expired physostigmine?
I want a rivastigmine patch.
You want
He wants river. Of course he does. He likes being delirious and agitated.
Anyways, okay. We can feasibly get through one more abstract here.
Okay. I'll behave.
And we have Dr. Kiernan and Dr. Comstock left. Who wants to talk about it more? Should you guys rock, paper, scissors live?
We can do that.
Let's do it.
Wait,
It's
before
gonna
you
be-
go, is it rock, paper, scissors, shoot, or is it rock, paper?
Oh, yeah.
We commonly accept it, I assume. Paper, scissors, shoot.
Since you listeners at home can't see this, please imagine a rock, paper, scissors battle of epic proportions, while each contender fought valiantly. Dr. Kiernan threw a fatal blow with rock against Dr. Comstock's cutting scissors.
Oh, ladies and
Devastating.
gentlemen.
There's a little bit of a hesitation move over there, but I appreciate the technique.
It was definitely the Zoom.
Okay.
Unstable internet.
Yeah, there's a delay. All right, let's hear it.
It's
What do
okay. We might be able to do both. This one, actually, I didn't even send this one to you, Ryan, but it was one that I found a little scary when I was at NACCT. So maybe we can try and squeeze both in real quick.
Abstract number 202. Enough negativity. Clinically significant salicylism with first detectable concentration 12 hours post-ingestion.
Like, we know salicylates can cause a Bezor in the stomach and you can have some delayed absorption. But I found this very concerning because compared to what our poison center guidelines are, they had a 19-year-old patient who came in after ingesting, I guess, first red flag, 78, 325 milligram aspirin tabs. So it's like 25 grams, 30 minutes prior to coming in. But was asymptomatic and had, I would say, like 4 or 5 levels drawn, and they were all negative up to 12 hours. And then, for whatever reason, later on, they checked another one like 12 hours later, and then the level went up and it ultimately peaked at 55, looks like. So just a reminder, kind of a scary reminder that absorption, like aspirin absorption, can be delayed and is erratic and does love to form Bezors in the stomach. And then they actually looked at another paper that was published where they looked at 313 aspirin poison patients, and 3.5% of them had initial undetectable level and then went on to have a clinically significant level, and one of those patients died. So again, just quick, reminder that aspirin is an over-the-counter med that can still throw you through a loop. That paper made me feel sad things.
Yeah, we've had one of these. We've definitely had one of these. I think it's something, I think the caveat to this that I personally think everyone should incorporate is that in particularly the ICU patients who levels have got up, they got into the ICU, not quite this one where it was negative to start, but the ones that you've admitted, because I have much more experience than you've seen it more often, where they are discharged to the floor. And the second they go to the floor, they're ad lib PO food, ad lib fluids, walking around, and all that stuff, I think, causes a renewed breakup and improved dissolution for a short period of time. And there's some interesting case reports that have been published out there on it. There's one with lithium where a woman was dialyzed 3 times twice because they stopped enteral products after she had been put on NPO and then stopped and then started and then stopped. I think that's something, this whole area is a mess. We really don't and have not studied dissolution and absorption with overdoses well enough at all.
Yeah, I think it's just a good reminder that you can literally never be sure you've ruled out salicylate until many days later.
Merry Christmas.
They even gave activated charcoal too.
Yeah.
Yeah.
Like everything about this case, just I saw the poster and I double take because it's another aspirin poster at a tox conference, and I was like, oh no, and it just kept getting worse.
I wonder if the charcoal actually played into a role there, because there is clinically significant desorption that has been shown, and I have the paper where there was a binding of it and then an eventual unbinding in absorption enterally.
Well, you could make the argument, Ryan, if you want me to argue for you against me.
Yes, I do.
It would be nice to know if the charcoal they gave was or was not given with sorbitol. If it was given with sorbitol, you're causing 2 problems. You're pulling more fluid into the gut, which could help with dissolution just from that alone. And then you're also minimizing the particles of charcoal interacting with the particles of drug that are in solution, because you're increasing the volume of the contact area so that it could make desorption better shortly, and it might not bind as much or as well because of it.
I agree. I think pretty much everybody would have missed this. This is 12 hours out before they had a positive concentration. But how long do each of your poison centers watch an aspirin overdose before you say, "Yep, we're good"? I've seen this, and I've seen a couple other cases and series, and what Frank's describing is clearly not unheard of. It's just like, God, do you watch all these for 12 hours? It seems insane, but
it's what is the acceptable risk?
This is grimace inducing.
By the way, you all did notice how the levels only got to 55 because they gave charcoal, and that's why charcoal should be used in everybody.
Correct.
Even that multi-dose charcoal, we can come full circle.
Well, repeat it.
I just echoing everyone else's comments. I think this case report this case just highlights the concern with salicylates in general, right? Is that it's hard to assess when you're fully out of the woods, and this is a quite impressive account. I'm glad they put this into a publication. It's interesting to see because that's a little terrifying.
And do you guys do any protocolizing for your poison centers? Are there, for us, for instance, it's like we'll check 2 levels at minimum if there's a history of salicylate. And if there's a really strong history, might check more than that and actually feed them and walk them around in between. Frank, you got 2 in the air. I don't know about you, Emily or Josh. 2. I'm seeing 2. Maybe. I'm not sure. Depends.
The feeding and walking around is interesting. I don't think we explicitly say that, but I might incorporate that or decorporate that now into my protocol.
Do you want to do yours in 60 seconds, Dr. Comstock?
Yeah, I'll give a 10,000 foot view.
Abstract number 267. High sensitivity troponin is frequently elevated after carbon monoxide exposure.
So it's a retrospective review of patients who came in with carbon monoxide or carboxyhemoglobin, percentages greater than 5. They have 267 patients who they evaluate with this. Of those 267 patients, 55 had elevated carboxyhemoglobins, and 17 of those had a troponin checked. All had a detectable high sensitivity troponin, and 12 of the 17 had elevated values. I think it's like greater than 10 nanograms per mil or something like that. So I bring this up not because it's practice changing, but it continues to confound me. And I just think it demonstrates that the authors seem to be as confounded as to what to do with this. I've for all time with carbon monoxide, I've not known what to do with troponin. I know it's elevated fairly frequently. It's, I think, 5% in previous studies or even higher, maybe 10%. Fairly frequent that it's elevated, but mortality isn't necessary. It's not a predictor for mortality. It's not a predictor necessary for delayed neurocognitive sequelae. And it's actually been studied and found to not be predictive of delayed neurocognitive sequelae, but BNP elevation has been. So, troponin is something that we're going to look at a lot more often than a BNP. And I think it makes more sense in our minds that will be the marker for injury to check. But now with the prevalence of everybody using high sensitivity trope, now we're always getting those. And in this study, you can see that it's fairly frequent that it's elevated. So I think it lends, I'm glad that people are starting to look at this, and hopefully some more of these data will start to trickle into the literature. But frankly, they looked at in this study, is there a correlation between carboxyhemoglobin percentage and the troponin elevation? They found the answer to that is no. Whether or not that's even the relation to look at, the relation of interest, I'm not sure. I don't think of carboxyhemoglobin percentage as being an independent predictor for DNS or mortality to begin with. So I'm not a person who thinks that the percentage by itself is a very meaningful number. And so I don't know that I would have looked for a correlation between the trope and the carboxyhemoglobin, but I think there's other things that maybe we can be checking for correlations of. So I think it's nice to see that the door is starting to open for people to assess what this looks like. This isn't the answer. And if anything, it just, misery loves company. And I feel like now I've got more company.
I think they highlight well that investigation is warranted to better understand the relevance and the value of continuing to use. And I've had multiple cases this year where we have people who are like, they clear their CO, they don't meet criteria, they have quote unquote cardiac involvement. So it's like, okay, do you need to dive them because their trope is elevated? That if you just Google CDC recommendations for CO, it's going to be right there. It says that. And there's and obviously that's a whole other thing. Who needs to get dove in the first place? And if diving does anything. But if you don't offer it, are you liable? I mean, that's kind of another thing. There's all sorts of questions that it brings into play. And then what happens when the trope continues to rise, but they have no symptoms and everything else is completely fine? That's like a big, and they've cleared their CO. It adds so much into the actual management conundrum that I don't know is standardized.
At least your misery has company, Ryan. You're not alone.
Well,
I could use lessons in brevity and directness from you, Dr. Comstock.
I like your way of going about it better, Frank.
We serve all audiences here.
Right. Well, I can't believe we got through all the abstract. Thank you. I really appreciate everyone providing their perspective on the limitations and value of all of the cases. I do want to also thank the authors of every one of these abstracts who put in effort to try to make something that we can use to take care of our patients better. And honestly, it's half the battle. So thank you. Thank you to you guys.
I'm grateful for your patience, and thank you all for including me on this, and take care. Goodbye.
Thanks, everyone. Have a good one.
Thanks for doing this, Ryan. I appreciate you having us. It was a lot of fun.
Yeah, thanks for having us, Ryan. Great time as always. Can't wait to hear the episode.
Well, wouldn't it be funny if I wasn't recording this whole time? No is the answer. It wouldn't be funny. Thanks for listening along. This was such a fun episode, and I hope you learned something. Let's do a 60-second review of everything we learned. Abstract 225. Methotrexate toxicity from therapeutic errors can cause serious problems, and we're trying to get better at triaging them. If you can educate your patients on how to take this drug appropriately, make sure you do. Abstract 251. Public health departments and poison centers can work together to prevent unregulated products with poisons in them from reaching the public. Abstract number 2. The antidote scene for cyanide is always evolving, and likely in the case of a mass casualty, we'll need an intramuscular antidote. Fortunately, we have some bright people evaluating what the best antidotes will be, and more is to come soon. Abstract number 10. The St. Paul's early discharge criteria is a good reminder of minimum criteria a patient should probably meet before being discharged after receiving naloxone for an opioid overdose, but its performance leaves a lot to desire. And in the age of novel synthetic opioids, there might be even more concerns. Abstract number 5. There's likely a reversal agent for THC intoxication that's going to come to market soon. It would definitely have a role, assuming the safety is there, in pediatric THC ingestions, but its introduction to the market could lead to some interesting non-overdose uses. Abstract 216. Physostigmine can be given if it's past its expiration date, although this is likely going to have a lot to do with what hospital you're working at and what their policies are. Many drugs still retain very good efficacy after they expire, and we shouldn't necessarily throw out vital medicines if there aren't other alternatives. Abstract 202. Salicylate can induce pylospasm and Bezor formation, and thus has erratic absorption kinetics. There are cases of patients developing toxicity despite serial negative levels many hours later. Because it's so tricky, it's a great idea to talk with your poison center about whether the patient who has a history of salicylate ingestion is actually ready to go home, even if their level is undetectable or low. And finally, Abstract 267. Troponin is frequently elevated after carbon monoxide exposure, and we know that cardiac involvement is not only potentially an indication for hyperbaric oxygen, but could be a sign of cardiac damage. There's a lot that we still need to figure out about what the relevance is of this elevated troponin, and if there are other better biomarkers like brain natriuretic peptide. Okay, that'll do it for today's episode. Thanks for listening along, and I hope you enjoyed it. If you like what you're listening to, please leave us a review wherever you listen to podcasts. It helps us reach other people who are interested in learning about toxicology. You can always follow the show on social media to see when new episodes are released. We're on Twitter at LabPoison. You can follow myself at PharmD. We have a Facebook page, The Poison Lab, and an Instagram, Tox_talk. Of course, you can find all shows, all free medical games, resources, and educational videos, as well as a shop for any Tox trinkets if you want to rep the show in your home state at www.thepoisonlab.com. You can reach out to the show anytime at toxtalk1@gmail.com. We love getting listener messages. And of course, keep your ears peeled. We'll be releasing mystery cases that you can guess what the toxin might be to take part of our next episode. So when you see one of those come out, be sure to write into the show. Okay, that's it for today. Thanks for listening, and I hope you can tune in next time. Hey Toxo, can you play us out?
The information on this show is for educational purposes only and should not be interpreted as medical advice or treatment recommendations. Contact your doctor for health questions or call your local poison center at 1-800-222-1222. The opinions expressed on this show do not represent those of our employers. This show is poorly written and shoddily produced by Ryan Feldman. Don't forget to give it a share with your nerdy friends. Cheerio.